Elaine Arkin, you may begin your conference.
Thank you very much, Rachel. Again, I am Elaine Arkin with the NCCOR Coordinating Center, and I'll be the moderator for today's webinar. Just quickly to go over today's program, we'll hear 2 presentations from a total of 4 presenters, Assessing Prevalence and Trends in Obesity, Navigating the Evidence, and then using NHANES to demonstrate applications. Thank you all so much for joining us for this, and we are glad to have you, and we want to have a chance to talk with you as well. So you can see the program includes a one-on-one session that's a question and answer time, and we'll have at the end a very quick review of some upcoming activities. Now, if you have a question for our speakers during the presentation, you've heard already that your phones are on mute. But please do write your question in the chat box. The arrow is pointing to the chat box on the right side of your screen. And we'll be monitoring those so that we can answer as many of those questions as we can during the Q&A session. If you're having trouble logging into the webinar but can hear us on the phone, please email us at NCCOR, NCCOR, at fhi360.org, and we'll work with you to resolve the problem and get you on the screen. And finally, one more important technical note. If you've decided to listen to our webinar on your computer speakers, please turn down or mute your computer microphone. There are a lot of us on the call, and it will greatly reduce the potential for background noise. So thank you very much. And just a couple of other introductory announcements. We'll also be live tweeting throughout today's webinar. If you're on Twitter or other social media, we encourage you to join the conversation by using the hashtag ConnectExplore and following the Twitter handle at NCCOR. Now, today's speakers. I'm delighted to welcome our 4 speakers today. Shari Barkin was the chair of the consensus committee we'll be hearing about today and is the William K. Warren Foundation Chair and Professor of Pediatrics, Director of Pediatric Obesity Research in the Diabetes Center, and Chief of General Pediatrics at Vanderbilt University School of Medicine. Lynn Blewett is a professor in the Division of Health Policy and Management at the School of Public Health at the University of Minnesota. She's also the director of the State Health Access Data Assistance Center, or SHADAC. Jackson Sejobo is the director of Evaluation, Research, and Surveillance in the Division of Nutrition at the New York State Department of Health. And Cynthia Ogden is the NHANES Analysis Branch and Chief Epidemiologist at the National Center for Health Statistics at the Centers for Disease Control. So before we hear from our speakers, we just want to pause for a minute to open with a brief poll. And if you would just answer this question, are rates of obesity stabilizing in the U.S.? I see you're answering already. Thank you so much. And in just a moment, we'll tell you the results, and we'll come back to this question during our question and answer session. Okay, so I think we are now closed for voting, and it depends is the lead response. And so 24 yeses, 20 noes, 50 it depends, and 8 unsure. So thank you all so much. And we'll talk a little bit about how it depends again a little bit later. Now I'd like to turn it over to Shari Barkin, who's our first Spotlight segment speaker on assessing prevalence and trends in obesity, navigating the evidence. Shari?
Great. Hi, welcome everybody. Today we're going to be talking about some of the highlights from the National Academies of Sciences, Engineering, and Medicine. The National Academies are a private nonprofit institutions that are called upon by the government and the private sector to help them to make informed decisions about complex issues, and they were established by President Lincoln under a congressional charter. Just to make sure everyone's clear on terminology, prior to March 2016, the Health and Medicine Division, which is called HMD, was known as the Institute of Medicine, or the IOM, but they're responsible for the same processes that I'm going to be reflecting today, the consensus studies and convening activities. So this particular activity was a consensus study, and when you see a consensus study from the National Academies, it's an end product of an intricate and involved process. This was our committee's task. So accurate and meaningful estimates of prevalence and trends are fundamental to describing and understanding the scope of obesity, yet different approaches are used to collect and analyze data on obesity prevalence and trends. And this has made understanding and using reports challenging. Therefore, our committee was asked to examine methodologic approaches to the collection, analysis, and interpretation of obesity prevalence and trends data at the national, state, and local levels, focusing on U.S. populations, and primarily focusing on children 18 years of age and younger. Additionally, the committee was asked to develop a framework to help policymakers and program planners assess reports on obesity prevalence and trends for decision-making purposes and to provide recommendations for moving the field forward. Today, we're going to be presenting information from the report just related to that first task, examining how obesity prevalence and trend data are collected, analyzed, and interpreted. This study was funded by the Robert Wood Johnson Foundation, and I was fortunate to chair this high-quality committee of experts whom you see listed here, some of whom you're going to hear later in this webinar. So there are many obesity-related questions that can be asked and assessed. However, our committee was given a very circumscribed task. Our charge was focused on looking at data collection and analysis methodologies and providing guidance to those who are trying to interpret and use that information. Many stakeholders utilize obesity prevalence and trend data to inform decision-making. We call these stakeholders end users of the data. So they span the gamut from public agencies to healthcare payers to data generators and researchers. So the information we're reviewing today is intended to systematically assist end users such as these in interpreting obesity prevalence and trend data. I'll begin with approaches to data collection. The report highlights the importance of and considerations for sampling, assessing weight and height status, and demographic characteristics. You'll note throughout our presentation the interdependence of population, methodology, and analysis, and how this can affect interpretation of obesity prevalence and trends. I'm going to begin with sampling. So it's typically not feasible or an efficient use of resources to measure every person in a population. Many data sources that appear in the obesity prevalence or trends literature use some type of sampling approach. The group of individuals participating in data collection through these different approaches can differ, and this, of course, would have implication for results and also meaningful subgroup comparisons. For example, how individuals are identified and who decides to participate affects the generalizability of the resulting estimates. As this visual depicts, if those who are selected and choose to participate are different in their obesity statuses than those who are not selected or decide not to participate, one can arrive at different estimates for the same target population. Some surveys, such as the Youth Risk and Behavior Survey, have used response rates as an indicator of representativeness. But we know that one number may not tell the whole story. An estimate that describes a broad population can mask what's occurring in smaller groups. A small sample size can lead to estimates that are not reliable. Sample size often limits subgroup comparisons, so sampling, especially subgroups of interest that comprise a small portion of the total population, is an important consideration. There are sampling approaches and techniques that can increase the representation of smaller subgroups, such as intentional oversampling. Intentional oversampling means a group or groups of interest are sampled at a higher rate than what exists in the target population. The next consideration is how weight and height status are collected, given that BMI reflects both weight and height. So weight and height can be proxy reported by a parent or a caregiver for children. They could be directly reported by the child or youth, or they could be directly measured. And in the chart noted here, small differences in height measurements, such as 2.6 centimeters for preschoolers, can result in different BMI categorization from normal to obese. And likewise, an overreport of even 0.9 kilograms can change BMI categorization. In older youth, larger differences in reported or measured height and weight result in BMI categorization shifts from normal to obese. So even with direct measurements, we see that there are a variety of protocols. For example, there might be a different number of repeated measures, or data entry measures might differ, or the equipment could be different. For proxy or self-reported heights and weights, interview questions can vary. For example, what you see in the chart here are variances such as time frame. They could say, how much does your child weigh now? Or in desired units, how much do you weigh in pounds? Or they might even indicate that your best guess could be fine. About how much does your child weigh without shoes? Your best guess is fine. Proxy reported versus directly measured generally do not lead to equivalent estimates of prevalence. In young children, error in reporting height largely drives these differences. Reporting error can also vary by child's age, sex, and weight status. Self-reported height and weight data often differ compared to directly measured height and weight data, but sometimes in a consistent pattern. So if we look broadly, elementary school-aged children do not provide accurate values when asked to self-report their height and weights. This can result in an overestimation of obesity prevalence. For adolescents and young adults, there's a tendency to overestimate height and underestimate weight, and as a result, self-reported height and weight data in these age ranges generally leads to an underestimation of obesity prevalence. While accuracy of obesity prevalence is affected, trend data in national data sources, such as the Youth Risk Behavior Survey, the YRBS, show a similar pattern and directionality to nationally representative estimates based on directly measured heights and weights, such as from NHANES, albeit at different values. The third thing I'd like to touch on in my section is demographic characteristics. While any variable can be used to create subgroups, the most common ones used are demographic characteristics. It's important to collect demographic information to determine representativeness of the sample, divide the sample into subgroups, assess disparities, and consider demographic shifts. Common demographic information needed to understand obesity prevalence and trends include sex, age, race, ethnicity, socioeconomic status, geographic region, and rurality. And many of these are collected with heterogeneous approaches. Two examples here. One is socioeconomic status. This can be reported as an individual household income or as highest education of one or both parents or caregivers, or as a community variable, such as percent of students eligible to receive free or reduced price school meals. Another example is race and ethnicity, and this can use specific pre-specified categories or open-ended lists that might indicate descendancy or ethnic origins. Not all data sources are clear about what geographic region and rurality is represented, yet these characteristics are associated with obesity prevalence and trends. Because different population groups can have different risks and rates of obesity, demographic shifts can affect an obesity trend. An influx or an efflux of groups with higher or lower obesity prevalence can affect the prevalence estimate for the broader population. And these changes over time can affect obesity trends. Therefore, an assessment of the stability of the underlying or target population provides context for interpretation. So the key messages from this part of the webinar include that sampling approaches affect what the data reflect for the target population of interest. Directly measured compared to reported height and weight data generally do not lead to equivalent estimates of obesity prevalence, but can result in similar trends reported. And demographic variables need to be considered to provide context for population estimates. You are all welcome to contact me, and here is my information. I'm going to turn it back over to Elaine.
Yes, thank you so much, Shari, for that overview. Very thorough and a lot of food for thought there, and I bet we'll have some questions a little bit later. Now I'd like to turn it over to Lynn.
Hello, welcome. Very glad to be with you today. I'm going to talk to you today about a couple of common data sources. And it looks like, there we go. So fortunately, there are a number of data resources at the federal, state, and local level that can be used to track and monitor obesity over time. It's important to be informed about these various data resources, but also which resource best meets your need for information. Each resource has its own target population, geographic area, and different ways in which data on weight and height are collected. The types of common data sources include population surveillance surveys, school-based assessments, clinical public health administrative data, and cohort studies. For many data sources, information on weight and height is just one component of a larger survey. It's important to understand the goals and objectives of the survey and the data that's collected. The data may provide you with important information on variables of interest, including target population as well as risk factors. A key distinction on data collection is whether weight and height are collected through actual in-person measurement or through self or proxy self-report. Measured weight and height, of course, being the most accurate. A practical way to think about data resources on obesity is think about the geographic area of interest. At the national level, NHANES collects in-person measured weight and height and is often cited as representing national trends in obesity by different age cohorts. The data are still cross-sectional, meaning that it doesn't cover the same people over time, but enrolls a different group of, but the survey enrolls a different group of people with similar characteristics for each year. NHANES does not provide information at the state or local levels, and then you want to look at other surveys that are of interest. There are some states that use data from the Behavior Risk Factor Surveillance survey at the state level, but also many states produce county-level estimates for statistical modeling of lower geographic areas. But again, these are estimates, and these are modeled estimates and not intended to be used to monitor trends over time. Every state fields a behavior risk factor surveillance survey and a youth BRFIS, and collects reported information on weight and height and is often used to monitor over time. These data are previously available and supported by the CDC. This chart shows you a number of different state and national data resources that can be used to monitor obesity over time. Our report provides information on each of these major surveys, including sample size, target population, and how weight and height are measured. Another key data source is based on program administrative data. That includes information collected on individuals who participate in a particular public program. M.S.H was a federal state program that aggregated weight and height data across state WIC programs. This national program has been discontinued, but state WIC programs still collect data, with some providing easy access to public data. A benefit of the WIC data, it is targeted on low-income children, a particularly vulnerable population and of policy interest. Another recent data source includes school-based assessments that are conducted for either screening purposes or surveillance. The screening is done to inform schools and parents of a particular need or particular concern about overweight children. A surveillance is done to monitor over time and to monitor and potentially to track the effectiveness of different interventions. We provide here 3 examples, including public schools in Arkansas, California, and Texas. There are many more that are included in our report. You can see wide variation of the grades assessed, the sample size, up to 1.3 million in California, who participate in the survey. There are emerging sources of weight and height data due to innovations in the role of technology, including electronic health records, now available in many clinical settings. We want to highlight more targeted, this information represents, are conducted in the clinic setting, and it's important to recognize that the target population only include those who visit the clinic. However, there are some innovations occurring that potentially could lead to a weight and height registry, and this work is currently being done in the state of Michigan. We also want to highlight the more targeted cohort studies, usually conducted to test innovations or address risk factors for target populations that are not always represented in larger national studies. These studies represent the conduct in the they're conducted in the clinical setting and in the community to assess the impact of interventions on weight and height, or well, actually on obesity. So key messages from this part of the presentation is that there are a myriad of publicly available data that can be used to assess and monitor levels of obesity in the U.S. This information is generally targeted to specific geographic and organizational levels, including federal, state, local, and school districts. It's important to know whether data are collected through on-site measurement or through self-report, and also to be aware of innovations that are occurring in the clinical setting, both in the collection and use of data through information technology, big data, and electronic health records. Thank you very much.
Thank you so much, Lynn. And here is Lynn's contact information. That was terrific, and it's nice that there's so many data sources. There's certainly a lot of differences between them, so perhaps we'll talk about that in the discussion section. So next, I'd like to turn it over to Jackson.
Good afternoon and welcome. The report defines analytic approaches as all analytical procedures that encompass data preparation and statistical analysis. The committee identified three key aspects of data preparation, namely obesity classification using reference populations. That's obesity classification using reference populations, identification and handling of biologically implausible values, or BIVs, weighting of data from complex sampling designs, and then under statistical analysis, key considerations include the role of the sample size, as well as the assessment of prevalence and trends over time. I'm going to spend a few minutes going over these key considerations under both data preparation and statistical analysis. Obesity classification is the first consideration under data preparation. Obesity is classified using different approaches in adults and children. In adults, the BMI cut point of 30 kilograms per meter square or higher is used to classify obesity status for both sexes regardless of age. In contrast, in children and adolescents who are still growing, the cut point for child obesity is determined by comparing sex-specific BMI for age to a reference population. This slide shows reference populations that have been used in published reports of child obesity prevalence and trends in the U.S. The 2000 CDC BMI for age growth charts are the predominant reference used for U.S. children ages 2 years and older. Other BMI for age references, which you can see on this slide, also appear in published reports and include the IOTF cut points and the WHO growth standards and charts. Different reference populations can lead to different estimates of obesity prevalence. Collectively, the committee recognized that current evidence indicates that difference in growth patterns among infants and young children are more attributable to factors related to environmental exposure and socioeconomic status than to inherent differences between racial and ethnic groups. The identification and handling of biologically implausible values, or so-called BIVs, constitute the second consideration under data preparation. BIVs refers to extreme values that may represent errors in data collection or entry. Some BIVs may represent true height and weight values of children who track at higher BMIs. Different approaches have been used to identify BIVs. Z-scores, which describe the number of standard deviations a value is away from the mean of a given distribution, are often used to identify extreme values based on established cutoff points for specific reference populations. Once BIVs are identified, how investigators handle them also varies. As stated earlier, not all values flagged as BIVs are errors. As such, excluding all data that are flagged as BIVs has the potential to underestimate obesity prevalence. Weighting figures prominently under the third and last consideration for data preparation, namely procedures to assess and achieve the representativeness of the study sample. The other two considerations are non-response and missing data. Weighting is an approach used to correct imbalances in sampling and better represent the target population in complex sampling designs. Not every study will have or need to have sample weights. For example, weighting is not needed when the sample represents the entire target population, as in the case of estimating obesity prevalence among children enrolled in statewide WIC programs in a given year, because in that case, we're dealing with a target, with the entire target population. Now moving on to statistical analysis. The first consideration here is the role of sample size. The larger the sample size is, the more reliable the estimate is likely to be. The size of a sample also has implications for subgroup analysis and assessment of disparities. Depending on the size of a sample, it may or may not be possible to generate small area estimates. Finally, eliminating or combining small or heterogeneous groups or combining multiple years for trend may be necessary depending on the sample size. Published reports present change in prevalence between two time points in terms of both absolute and relative change. Absolute change is defined as the simple difference between two prevalence estimates, while the relative change is the percent change in prevalence and is dependent on the baseline prevalence estimate. This figure, as you'll see, is from the consensus report and shows two scenarios in which absolute change is equal, but the relative change is different. This highlights the importance of the initial prevalence estimate in interpreting the relative change. As part of its charge, the committee was also asked to consider approaches to assessing and comparing trends among diverse populations. In terms of analytic approach, the report recognizes that trends are defined by the start and end times. The more time points there are, the more nuanced the trend analysis can be. When comparing trends, the report highlights the importance of adequately characterizing the populations within each study or population subgroup by person, place, and time, as well as considering the analytic approaches. In addition to ensuring the comparability of the geographic areas represented by the different study populations, the committee recommends that end users ensure that time frames and intervals used in different analyses are similar and that the analytic approach is consistent across the time points within a study and is comparable across reports. The key messages for this section of the webinar include the following. Obesity prevalence in children can differ depending on the reference population used. Biologically implausible values can affect the prevalence estimates. Interpretation of trend estimates includes consideration of the person, place, and time, as well as the analytic approach involved. I will now turn it over to Elaine.
Thank you so much, Jackson. It's a great framework for analysis, and I see there are questions coming in. I will turn it back to you for a minute, Shari, about a few additional resources.
Yes, what we've done is Lynn and Jackson and I have just given you a tiny taste of the report. The report is 285 pages long. There is so much more there for you, and I see that some of the questions are specific about what's out there. We have an incredible appendix to try to show you the variety of data sources that exist out there. And this is how you would get the book, so you could learn more about it by going to this website. The other thing we wanted to highlight for you, we didn't get to cover the other pieces of the report, but you'll be able to either, if you don't want to read 285 pages, you can get this book. And this booklet here is really a summary of key findings if you just need the at-a-glance version. And then here we also have a very easy, interactive way to utilize the framework to systematically assess reports on obesity prevalence and trends.
Thank you, Shari. And I just want to point out to the right of the slides under web links, there's also a direct link to the report. So now I'd like to turn it over to Cynthia.
Thank you, Elaine. Well, you've heard a lot today, and you've heard mention of NHANES, and I know many of you are probably very familiar with NHANES, which is the National Health and Nutrition Examination Survey. As many of you know, it is the gold standard for estimating national prevalence of obesity, and that's because two reasons. One, it's a nationally representative sample, but two, and more importantly, it contains measured weight and height. And in fact, the measurements of weight and height go directly from the scale and the stadiometer into the database, so that the data actually are very clean. But there are limitations to NHANES, and the big one is that it's a relatively small sample size. Only approximately 5,000 people are surveyed each year. And the data are released every 2 years, and that's about 10,000 people. And that would be from age birth all the way up, the entire population. So for subgroups, you have particularly small samples. I'm going to now use NHANES data to illustrate 5 of the different concepts you've heard about today. Measured versus reported data, different reference populations, BIV, or biologically implausible values, small sample sizes, and start endpoints. So I'm going to start with measured versus reported data. This graph shows the prevalence of obesity from NHANES on the red line, and then YRBS in the blue line for adolescents over the time period from 1999 to 2013. And you can see clearly that the prevalence is lower based on self-reported data. In fact, it's about a third lower, 13.7% versus 20.6% in the most recent survey period. And this is because, as you heard earlier, there's an underreport of weight and an overreport of height. And this pattern is very similar to what you would see in adults, where you have the misreporting of weight and height. Now, on the other hand, if we look at the prevalence of obesity based on measured weight and height and compare it to parental report of weight and height among young children, we see the reverse. We see a much higher prevalence based on a proxy report compared to measured data. This graph shows in red the prevalence of obesity from NHANES, and then in blue the prevalence from the National Health Interview Survey, which is proxy reported. And the survey period time is 1999 to 2004, but the point really is this comparison between the measured and the proxy reported data. And you see that for the 2 to 3-year-olds, it's almost 5 times higher based on proxy report. It gets a little bit better by the ages of 6 and 7. It's only 4 times higher by proxy report. And this is because parents underreport height. They're more likely to report a closer to accurate weight, but they underreport height because kids are growing. The work from this study actually contributed to the decision not to show or not to include data for under 12 years in NHIS. All right, turning to different reference populations. You've heard about several of them, the WHO growth standards, the CDC growth charts, and the IOTF. So different reference populations will give you different estimates. And so this graph shows you in purple the prevalence of high weight for length among young children birth to 24 months of age based on the WHO growth standards, and compares it to the prevalence based on the CDC growth charts. And you can see the prevalence is 8.1 versus 9.1%, so that you can get different results depending on the reference population. But if you look at trends over time, you should see the same trends if the age distribution is the same. So this graph shows the prevalence of high weight for length using the CDC cut points on the green line, and then the WHO standards in the purple line. You can see the patterns are the same. But an important item here is that the age distribution has to be the same, given that the growth charts are by single month of age. What about BIVs? How do we find them? How do we define them? And just to reiterate, NHANES is relatively clean, and so I'm going to use NHANES as an example to show you if you apply a BIV criteria to NHANES, you will actually exclude real data. So this is the prevalence of obesity in the U.S., and we have just the general prevalence. The dates are 1999 through 2012. And in the red is just the general population of youth 2 to 19. So 16% overall and 20.3% among non-Hispanic Black youth. And if you then you apply the WHO criteria for BIV exclusion, you actually drop down to 15.5% and 19% in the two groups, and you're really excluding real data. And so you might consider comparing data to maximum NHANES values to provide some guidance in terms of BIV. And then what about small sample sizes? This table shows the sample sizes for different age subgroups in NHANES in 2011-12. And you can see that the sample sizes decrease the younger the children are. And I also included the number of children with obesity on the right, just to give you a sense of if you want to look at just that group of the population, you'd have a very small sample size. This translates then into less stability and some bouncing of estimates. And so in this graph, you see all the data we have on child obesity back to the 90s by age. You see the 2 to 5-year-olds in purple, then in green is the 6 to 11-year-olds, and then in orange is the 12 to 19-year-olds. And you can see in the most recent survey periods quite a lot of bouncing because the sample sizes are relatively small compared to the earlier survey periods, which included more years. So it's only since 1999 that the data have been released with just 2 years of data. And if you increase the sample size by combining years, you can see in this graph that the estimates are actually more stable. There's less bouncing. And although you can do statistical tests of trends with the many data points with the bouncing, and in fact that's a good thing to do. If you want to actually see the trends, you can see it a little bit better when you actually combine survey periods and look at those trends. And so then the last point is, over what time period are you going to look? What are your start and end time points? And for this example, we're going to look at U.S. adults. And this graph shows the prevalence of obesity between 1999-2000 and 2009-10 in women in purple and men in green. And during that time period, the prevalence went up in men, but there was no change in women. If we look between 2003 and 2004 to 2011-12, there were no changes in either men or women. The most recent decade, however, between 2005-6 and 2013-14, saw an increase in women, but no change in men. And so you can see that uptick in women in purple in the most recent survey period. But just to give you a better flavor of where you look and what your snapshot is, this shows all the data back to 1960 for adult overweight in men and women, obesity in men and women, and extreme obesity in men and women. And you can see how the trends, in particular related to obesity, have varied somewhat depending on which time period you look at. Overweight, it looks more stable over the time period, but obesity, if you pick have a window of 10 years, and depending on the 10 years you pick, you'll get a different answer on trends. Okay, thank you very much.
Thank you so much, Cynthia. And we are now ready to turn it over to all of you. Cynthia, it was great to have an in-depth look at one data source to bring this back to reality here. So that was terrific. There are a lot of questions, and I just want to remind you that you are welcome to type in questions in the chat box if you have one. We'll answer as many as we can, and following the webinar, we'll explain to you. We can answer others online. So just as we get started, Shari, would you like to bring us back to that poll question and tell us a little bit about why it depends?
Well, you could see that the majority of you picked it depends. And And with some of you saying yes and some saying no and a few saying not sure, but 49% said it depends. And I hope what we've been able to show you today is why that's the right answer. So we know it depends because it depends on the sampling and who is represented in the data source that you go to. It depends on the sample size and the demographics and how they were collected so that you can understand subgroups. It depends on how those subgroups were defined. And within subgroups, if there was homogeneity or heterogeneity, it depends on how height and weight were measured. And I think Cynthia just did a really nice, took us through a high-level view of how that changes. It depends on the time period, that last slide that you all saw, and what Jackson presented, the time period over which data were collected, and also how biologically implausible values were handled. So, and then one other thing, and I noticed we've got a long list of questions, so I'm gonna end shortly. But I think it's really important, and several of these questions make mention to this, that it's important to understand which geographic area is this reflective of. So if you're fortunate to have a national view versus a state or a local view, you have to understand how your geographic region was defined and also what rural population was included, because that can really shift what your findings are in terms of prevalence and trends.
Thank you so much, Shari. And I'm just going to keep moving through these questions because, as you mentioned, there are a lot of them. So the next one is, can you describe how you assess for disparities in the obesity prevalence data? And Lynn, I think you had some ideas of data sources for that.
Well, I would start just saying that, excuse me, many of the major surveys, NHANES and BRFIS, often oversample different population groups. So it's important to check with your state on their sampling methodology. Excuse me. And then I'm going to have to go turn this over.
I'm just going to, this is Shari. So I think this is a really important question, and to understand and assess disparities, you have to be really clear about how you're defining disparities among whom, and you have to consider also the interaction among those variables in terms of age, sex, gender, socioeconomic status, race, ethnicity. And so that's why it seems like it should be a straightforward question, but it isn't. And I think what Lynn really wanted to highlight is that you can look at those samples that have larger sample sizes, such as NHANES and BRFIS, because they oversample with the hopes of answering more of those questions.
Thank you, Shari. And the next question was, I believe, for Lynn, but Lynn, I'll let you talk or not talk. And the question was, will there be a discussion of how to derive synthetic estimates by geographic area, that is state, county, city, and trends over time with the rolling averages? Boy, that could be a great 3-hour discussion. But Lynn had a great reference, and Amanda has just posted it in the chat box. So thank you for that quick work, Lynn, to provide a reference there. Lynn, is there anything you want to say, or are you still?
I'm good, thank you, and I apologize for that break. I've got a terrible cold, but I think you've covered it all, and the CDC report that Amanda posted is really excellent in terms of the method that they use with the BRFIS to do small area estimates, so I would suggest starting there.
Great, thank you very much. Next question, is there a recommended way to exclude BIVs without affecting the representatives of the population? Namely, is there a way to parse out which BIVs are erroneous versus which are true values? Jackson, I believe this one's for you.
Yes. So there had been established cutoff points by CDC using the 2000 CDC reference population. And those have recently been updated to basically reflect those children whose height and weight values track at higher BMIs. So we do now have newly established cutoff points, which on the upper side go up to 8 for some of the values, Z-score of 8 when previously it was up to a Z-score of 5. And the report does have a specific table outlining the lower cutoff points as well as the upper cutoff points for Z-scores for the WHO, but there's also references available for the CDC cutoff points. So the answer to this is that now we do have, through these updated CDC cutoff points, an ability to actually include in the calculation of the prevalence estimate those children who actually may whose values are not necessarily BIVs.
This is Cynthia. Could I just chime in here too?
Do.
Another option is to compare values to the maximum values in NHANES because we know that those are pretty clean.
Great, thank you. Anybody else want to comment on that? Okay, so next question. Is there a recommended method for handling missing data or incomplete data sets with childhood obesity prevalence data? Who would like to handle that one?
Hi, Jackson here. There are different ways to handle missing data, but for the purpose of the report, the focus was really on emphasizing the need for when comparing across reports or even when conducting new studies to think about how missing values were handled in those studies that may be of relevance for comparisons in the future, but also thinking in terms of just end users to the extent that how missing values are handled, and we know that they have implications for the achieving representativeness of the sample. So what's important is to really ensure consistency in how the missing values are handled. Obviously, in some cases, there could be multiple imputation. This is where basically the observed values are used to estimate values for those responses that are missing. And then in some cases, the missing values may be excluded entirely if the number of missing values does not necessarily represent a significant proportion of the overall sample. So I think the message for end users is really to ensure consistency in terms of the analytic approach that was used to handle missing values, because that then ensures that there's comparability across reports or across a particular study and those of relevance in a particular geographic area. Related to the question on synthetic estimates, again, even there's the same approach, because whether you're using synthetic estimates that are generated using prevalence data for adjacent counties or adjacent census tracts, the idea is to make sure that the methods used are consistent to facilitate comparisons, because part of the challenge, as Shari pointed out, is being able to assess whether or not trends are changing or in particular directions, whether they're increasing or decreasing in certain geographic areas. And it's very difficult if the methods used are not consistent. If the analytic approach, both in terms of data preparation, which is missing data, falls under that one, as well as under statistical analysis.
And this is Cynthia. And another point in terms of missing data, sometimes if it's a complex survey, you can reweight the data, and if you have a lot of missing data, it's another thing to think about.
Thank you both. Anybody else want to comment on that? Okay, so next question. Can anyone provide an example or two about how to publicly interpret findings from different sources, specifically state surveys versus NHANES?
Well, I will start and then let Cynthia add to what I say, or maybe correct me. But typically at the state level, it's based on self-report or proxy self-report. And there's quite a bit of evidence that people respond differently to a self-report about their weight and height. For example, in the Youth Behavior Risk Factor Survey, students tended to underestimate their weight by about 3.5 pounds and overestimate their height by about 2.7 inches. And that's different depending on whether it was male or female. So it's important to understand that the self-report is not going to be completely accurate. However, it is a source of information that's useful and available and is often used and in advocacy and education, and is really an important part of the framework of monitoring and assessing obesity. And I'll let Cynthia add another comment from her perspective, which, you know, the NHANES, which we'd all like to do measured weight and height at the state and local level, but it's very expensive and time consuming, and it's something that it's just very difficult to do.
I guess the only thing I would add to that is that you can also have differences in reporting depending on the method of reporting. If it's a telephone survey versus an in-person survey, actually you can have the reporting can be different. And so one of the interesting things about NHANES is there are questions about reporting weight and height, but those questions, that when you look at self-report in NHANES, it actually doesn't match that closely to other self-reported surveys. And we think that's partly because people know that they're going to be measured later. So you can have over the phone, in person knowing you'll be measured later, and so you would have different results. But you know, they all provide some information. It's just different. It's reported. It's what people think or what people are reporting. That's about all I have to say.
And this is Shari. I just wanted to add, because I see Susan's question here, and it depends on what you're looking for. So, for example, when you want to understand how you interpret the findings, let's say you're interested in a certain race or ethnicity or socioeconomic status, looking at just the overall summary of the report often doesn't give you those granular details, but typically if you're looking specifically to answer that question, you're going to be able to reach into the data that are presented so that you can utilize them to answer the question that's important to you. And it was for that reason that we, as part of our task from the committee, we designed something called the APT framework, which is Assessing Prevalence and Trends in Obesity, to try to help people like Susan answer that question in a really systematic way. And you can find that also on the link that's provided here.
Thank you all. We have time for just one final question. We actually are a little bit over, but it's kind of a nice closing question. And I think this is for Cynthia. And our participant says, am I correct in saying that severe obesity in children and adolescents has increased over the years?
So the answer is it depends.
Nice way to bring it full circle.
Yes, you know, it depends on what age group you're talking about, and it depends on over what time period. If you look over the last 25 years, it's been increasing, particularly in teenagers. Over the last 10 years, we've seen no significant changes, but that's because among teenagers, the changes have been very, very small.
Anybody else want to comment on that? Shari, that goes right back to what you were talking about, looking more granularly at the data that you're considering. So, thank you. We don't have time for additional questions, but if you do have further questions, please email the NCCOR Coordinating Center, or the chat box is still open for another minute. We will be able to answer some remaining questions by email as a follow-up to this webinar. And just a quick couple of announcements. This webinar will be, just as with all Connect and Explore webinars, it will be archived on the NCCOR website. And you can see here the website. If you use the top navigation and click on webinars, all of the upcoming and archived webinars are displayed there. So if you have colleagues who were not able to join, please let them know that it will be up within the week. We have an awful lot of use of the archive material. So again, thank you. Thank you so much to our great guest speakers, so well prepared, and I love those key messages. Shari, Lynn, Jackson, and Cynthia, and to all of you who took your time this afternoon to be with us.